Good morning. My name is Andrew Thomas. I'm Chief Clinical Officer for the OSU Wexner Medical Center. It's a pleasure to be joined by a number of representatives from local and statewide media to have another COVID-19 media briefing. I'm joined today by two of my very well-respected colleagues on these topics. Dr. Christina Liscynesky, who's one of our faculty in infectious diseases and one of our hospital epidemiologists, focusing a lot of her time on the James Cancer Hospital, as well as taking care of patients across the medical center with COVID-19. And also Dr. Sara Koenig, who actually is our lead scientist around our COVID genetic sequencing lab and the Director of Special Technologies related to COVID for the OSU College of Medicine. It's really a pleasure to have both of them here with us this morning. So we're going to start with just a little bit of background of where we are with case numbers here across the state of Ohio. I'll share my screen. What we're looking at on the top left are case numbers since the beginning of the pandemic for the state of Ohio, and at the bottom right, case numbers just in the past 30 days. Each blue vertical line, vertical bar, are the case numbers that are announced each day by the Ohio Department of Health. And then the blue line is a 7-day moving average trend line. What you can see where we're at now at about a trend line of about 7,500 cases per day puts us actually right about where we were at the peak of the Delta pandemic or the Delta variant surge back in September, and really about 3/4 of the way to our peak numbers back in the winter of last year. And if you look just in the last 30 days, we've gone from a 7-day moving average of around 5,000 cases per day to just over 7,500, which would be a 50% increase in case numbers just in the past 30 days. Just to remind folks, when I talk about zone 2, what I'm talking about, it's regions 4, 7, and 8. So the counties here in central Ohio going northwest up to the Bell Fountain area and up to Upper Sandusky. And then everything to the east and southeast and directly south of us in regions 7 and 8. So in zone 2, what are we looking at? These are numbers through yesterday. Where we're at around 900 patients with active COVID in the zone. We topped just over 1,000 patients back in September. And we were 1,200 patients back this time last year in the winter of 2020 going into 2021. So what you can see is we got to a low number in early November and really have been on a direct upward trajectory over the last 5 to 6 weeks to the point where we're now back almost where we were in the Delta surge over the summer. If you look just at the Franklin County adult hospitals, you can see we've actually surpassed where we were this past summer in terms of the Delta surge. So we are over 400 patients. Now we were at 600 this time last year, so not quite where we were this time last year. But as many of you know, all of our hospitals across the state are now struggling in terms of staffing, in terms of staff, in some cases being out ill from community exposure. And in other cases, frankly, staff that this time last year were more than happy to work overtime and work extra shifts to try and take care of a COVID surge prior to there being a vaccine. And our staff are burned out, they're tired. The people are not able to stretch themselves as far as they were, and we're not able to add beds, add services as we need in the same way we were a year ago. So I think all of the local hospitals and all the hospitals in our zone are really expressing concern about where we're going with this surge of patients over the last 5 to 6 weeks. And just want to make sure that we're sharing that concern with the media. So we'll turn to Dr. Liscynesky for a short discussion about the types of patients she's actually seeing in the hospital when she's on rounds as an infectious disease specialist who have COVID-19. Christina, can you give us just a little snapshot of what you're seeing on an average basis?
Sure. So we see basically 2 buckets of patients. One is going to be our immunocompromised patients. So I primarily round in our cancer hospital. And so these cancer patients, range anywhere from people with solid tumors such as breast cancer to people with severe leukemias where they don't have any white blood cells to fight infection. And what we see is that our patients who are fully vaccinated as well as boosted, who come in with COVID from the community, they do fairly well with their COVID. We treat them quickly if we can. We ask that they specifically monitor people who just in general for our patients, we ask that they be very vigilant about developing any symptoms of COVID, get tested very quickly, and if they do, to let us know right away, because we do have a monoclonal infusion that we can give as an outpatient. That is very helpful. So that's one bucket of patients, and we're fortunate to be able to sometimes treat them very quickly, and then they're able to go home without any issues. The second bucket of patients we see are people who are critically ill, and they are typically unvaccinated people. That is clearly the biggest risk factor. Also, people who have medical comorbidities and are unvaccinated. That's a bigger risk factor than being young and healthy and unvaccinated. So I think the biggest take-home point is that, you know, if you're over age 50 or if you have any medical comorbidities, including being overweight, you absolutely need a vaccine because this disease does cause severe illness in those patients. Unfortunately, those patients also are not patients who present to the hospital early because a lot of times you hear that they feel like they're maybe going to get better at home. And in general, this virus, it doesn't get better at home. So it's one of those things that you need to be very vigilant about, and you need to call your doctor quickly and get tested quickly. It's also important to prevent spread as much as possible. If you have a family member who is a immunosuppressed patient, it's important that, you know, we want to have a ring of vaccinated people around those very vulnerable people. So that is why it's important, you know, for children to be vaccinated as well as younger people. I personally, you know, have had my booster to protect my grandparents as well as my patients in the cancer hospital.
Thanks, Christina. You mentioned getting treated quickly. Can you briefly update the media on where we are with the monoclonal infusions? I know we've just about to cross 3,000, I believe, infusions provided.
Sure, we are incredibly lucky to have a robust monoclonal infusion program here at Ohio State. And we have been fortunate to be able to just place a consult for this. And this happens, you know, 6 days a week now here at the medical center. And it's incredibly helpful. Anecdotally, what we hear from patients is they feel much better after the infusion. It's really important, though, that this needs to happen within 7 days of symptom onset. And really, quite frankly, it needs to happen within the first few days. So if you're notified that were exposed to COVID, if you have any symptoms, you know, runny nose, sore throat, feeling fatigued, please go get tested. And then please notify your physician immediately if your test is positive, and then we can get this process rolling. And that's actually, yeah.
Since the monoclonals are focused around high-risk patients, can you just walk through what those criteria are for the infusion?
Sure, it's over age 65. Anybody over age 65 is eligible, and then people with medical problems under age 65. So heart disease, diabetes, if your BMI is if you have a high weight, you also are qualified, and that's something that your doctor will calculate for you. Any sort of respiratory illnesses, obviously anybody with cancer, a transplant, or advanced HIV.
Any sort of immune
compromise.
Mm-hmm. Exactly. Great. Thank you. Mm-hmm. Sarah, we're going to turn a little bit to genetic sequencing. Before we get into what was announced over the weekend in the Omicron variant, can you walk just briefly for our friends in the press through how the sequencing process works when someone has a positive COVID test?
Yeah, absolutely. So here at Ohio State, we are testing every single specimen that tests positive for COVID-19. We bring that back to the sequencing lab. And these tests are coming from OSU patients, from community swab stations, from external medical centers that use our testing services. And we bring it into the sequencing lab, amplify the extracted viral RNA, and then our sequencing technology allows us to read the viral genome like a book. So we can see the specific nucleotide makeup. So all genomic material is made of 4 nucleotides represented by the letters A, T, C, and G. And through sequencing, we're able to figure out the 30,000 sequence orientation of those A, C, T's, and G's. And then we are able to compare them to these international databases to see exactly which variant strain it is.
That's a really great summary. in just a few sentences. That's outstanding. So let's go to what was announced on Saturday. I know we put your team on alert, working double time over the Thanksgiving weekend when the Omicron variant was first announced the day before. Can you talk a little about what your team has been up to the last few weeks and then what we announced on Saturday?
Yes, absolutely. So at the beginning, I guess, of the Omicron announcement, which was around Thanksgiving, we started sequencing much more frequently. So we had already been doing every positive sample that comes into the medical center, but we started doing it more frequently so that we could decrease our turnaround time and identify Omicron faster when it arrived in Central Ohio. And so fortunately, we were able to identify it 4 days after the sample was collected, which is significantly faster than would be expected from a sequencing lab.
Great. And at this point, we're still sitting with only 2 samples that have Omicron, correct?
Yes, that's correct.
And that's out of how many tested since Thanksgiving?
We've done over 1,000 tests, so we're looking at 0.2%.
That's outstanding. I think what I've been hearing is the progression they're seeing in some other countries and certainly some other states would expect us to see this outcompete the Delta variant. But really right now, to your point, we're 99.8% the Delta variant, correct?
Yes, that's absolutely correct. And I was reviewing some of our data earlier today when the Delta variant was first present in Central Ohio and took over. And, Delta took approximately 6 to 8 weeks to really be the dominant variant. So I think these things do take a little bit of time.
Great, thank you. Christina, when you counsel patients about their positive test or about what to do to protect their loved ones and family members if they have a positive test, does the factor of what variant they have change at all what they should be doing with isolation or how they take care of themselves?
No, not at all.
Really, it's the same, not sleeping in the same room, not using the same bathroom, not using cups and utensils. Because oftentimes, to Sarah's point, we don't know what the variant is for days afterwards. It really doesn't change what someone needs to do.
Correct. And in general, we've seen sick patients both with Alpha and with Delta. So that would not be a decision that I would make as a clinician what variant it was.
Excellent. Can we talk a little bit, Christina, about vaccinated patients who are testing positive, whether they're boosted or not boosted, and how we can make sure those folks that have kind of minimal symptoms are protecting others around them?
Sure. So, mask wearing is incredibly important, as well as testing early. So now we have, the Columbus Public Libraries, we're handing out antigen kits, which is a test that you can do over the telephone. You download the app. And then we also have, there's robust testing throughout Central Ohio and throughout Ohio. So just get tested quickly if you have any symptoms. It is important to isolate so that you don't spread the virus to other people. Now, the point of the vaccine is so that people do not get severely ill and critically ill and die from COVID. So that's the main point of the vaccine, is that we don't want people to die from a respiratory virus. There are thousands of respiratory viruses around. For example, just to be kind of my nerdy ID doctor, there are 120 different types of adenovirus. So that's one of the viruses that causes pink eye or the common cold. So there's 120 different types of that, and we can only really test for like 3 of them on our clinical platforms. So the goal of the vaccine is not to necessarily get rid of COVID forever. The goal is so that people don't die from the disease. So in the way to prevent people, who are at high risk from dying is, number one is to get vaccinated. And number 2 is to not expose them to the virus. And that's why we wear the masks and why we vaccinate ourselves as well.
Great. Thank you so much for that explanation. Now we'd like to open up to our colleagues in the press. If there are any questions, please feel free to put if you have a question, you can either enter that in the chat or raise your hand through the raise your hand function. Alexis Moberger from Channel 6.
Hi, yes, thanks so much for taking our questions. We've seen in some states, just with the hospital capacity and also with a lot of the, worker shortage that we're also seeing, the National Guard deployment. Would this help our hospitals here in the state, or where are we at, I guess, we even saw with Cleveland Hospital that they're starting to get with those worker shortages pretty bad. Where are we really in Central Ohio, Franklin County area?
Alexis, that's a great question. I think we talked about this briefly last week, but as things move forward, it's important just to remind folks that Metro Health, Cleveland Clinic, and University Hospitals of Cleveland all announced just about 10 days ago that they're putting a hold on elective surgeries for about a month-long period of time because of the surge of patients they're seeing in the northeastern part of the state. In fact, that area from kind of Mansfield, Worcester, Canton, Akron, Youngstown, that southern part of Zone 1 is probably the hardest hit in terms of the percent of their population that's in the hospital now. Last time I saw, I believe there are over 2,500 patients in Zone 1 in the hospital. So they certainly are feeling it. We're feeling it here locally. There are a number of local hospitals in our zone that are either on a day-to-day basis assessing elective cases or are making that difficult decision that for a 2-week or 4-week period, they're going to kind of postpone elective surgeries. And we're not talking cosmetic things here. We're not talking about that sort of elective surgery. What we're talking about is people that were scheduled to have a knee replacement, people that were scheduled to have back surgery, people that were scheduled to have bariatric or weight loss surgery. Those are things that could be safely postponed a month. But for those patients, that's a huge impact. We're not going to be delaying cancer surgeries. We're not going to be delaying life-saving open heart surgeries, things like that. But for those things that can be safely put off, there are a number of hospitals across the state that are making that difficult decision based on what's going on in their local environment. So in terms of your question around the National Guard, obviously you should probably refer that question to the National Guard. And General Harris has been an outstanding partner from the beginning. But what I will say when we discussed this with them in the past is that for the most part, for example, the nurses that are National Guard members are also the nurses that work in our hospitals. So it's a little bit of essentially cannibalizing our own workforce to pull them out for guard duty and then send them back to the hospital. It really doesn't help a lot. That being said, they have a number of folks in the National Guard that are very, very helpful. So people that are good at driving and transportation, people that could help us like EMTs that in many cases have helped us at our testing sites or have helped us at vaccination sites in as a runner, all sorts of things. Because when you talk to the hospitals in Northeast Ohio, we just had a call this morning at 6:30. A number of those hospitals now have hundreds of staff that are actually out with COVID. So we're back to, who's going to deliver the meal trays, who's going to clean the rooms, who's going to transport patients. And that may be the most effective way that the Guard can help us. And I know General Harris and his team are looking into those options actively.
Thank you so much.
We have a question from Spectrum News. I apologize, I'm not getting the name. Rodney, maybe? Rodney.
Yeah.
From Spectrum News. Yes.
Yeah, my name is Rodney.
I'm sorry.
No, not a problem. Not a problem. I just kind of want to also follow up on Northeast Ohio hospitals being overrun with patients. Do we know if all of these patients are there with COVID, or are there also patients there that are, as you said, elective surgeries have been postponed, people who maybe have had their stuff postponed for months and now their symptoms are getting worse? Are we being overrun by those patients as well?
Well, it's a great question. And I do think it's kind of a both and situation, not an either or. We are seeing high numbers of COVID patients, as I just went through here in our part of the state. There are higher numbers even than up in the northeast part of the state. But what we're also hit with is the highest, what's called case mix index or level of severity of patients for non-COVID patients that we've seen, at least at Ohio State. It's higher than we've seen at any point prior to the pandemic. And some of that is because people have put off some healthcare that they needed prior to this. Some of it is people that have stopped exercising during the pandemic, all sorts of other things that people were doing to keep themselves well. We know that the mental health crisis has gotten worse during the pandemic, as in some cases people have felt isolated or maybe lacked some of the same social support they've had before. And in some cases, people, for example, with underlying liver disease that might have been drinking more during the last few weeks or months are showing up with worsening of their cirrhosis and other things. So it's kind of a double problem, and those two things together make things exponentially harder to manage, because a lot of those medical conditions and medical situations, that care cannot be delayed. So we'll talk to rural and community hospitals that might have a 30-bed emergency department. Their ICUs and their hospital beds are full, and they have 10 or 15 patients waiting for a bed in a 30-bed ER, which means their ER is now a 15-bed ER. And we struggle with that here as well, with boarded patients waiting for a bed in our inpatient setting. So it's definitely a combination of high numbers of COVID patients, but then also high numbers of sicker patients with non-COVID illnesses that are driving a lot of the concern and the stress on our healthcare system. Pete, do you have a question? Oh, you said never mind. Let's see if there are any other questions that have come in. Sara, can you talk a little bit about the timeline at which we might expect the Omicron variant to become the dominant variant here in Central Ohio?
Sure. So like I said earlier, when we saw Delta from the first time to when it became the predominant variant, it was 6 to 8 weeks. We have reason to expect that Omicron will be working on a faster timeline. And so it's I would predict within the next 2 months. But also it's going to be based on the samples that we're able to get on our hands on, right? So we're only sequencing samples that have been PCR tested. There's a lot of people that are doing at-home tests or tests, I guess, through like CVS or another drugstore. So it's really what we know is based on the tests that we're able to get our hands on.
Great, thank you. One last time to query our friends in the media. Are there any other questions for the group today?
I do have one other question, if possible, just about herd immunity. I mean, where are we at that point with, the percentage of people vaccinated in the state, the number of people getting COVID? Where are we just kind of as far as herd immunity?
Christina, do you want to start with that one?
That's a tough question. It's a great question. Every time we have a surge, we're always hoping that is going to be the last surge that we're taking care of here at the medical center and within our patients. I think the long-term thoughts are that eventually the virus will become less virulent, so it will become less destructive, and it will end up going into the common cold because we will have some inherent protection in our own selves because we were infected in the past. I don't have a specific number for where we are with herd immunity there, but I think the long-term plan is that hopefully we're hoping the virus becomes less virulent.
Are we seeing that with Omicron? I guess, like, are we still thinking that it's a less severe version than the Delta?
We don't know yet. So, and I think from our standpoint locally, from an infectious disease standpoint, well, obviously we all have offices in the same hallway up here, and it constantly are communicating. And so when we start to see cases here that look different than Delta, we'll readjust what our treatments are going to be and readjust what we need to do. But we haven't seen a case yet.
Yeah, no, Alexis, I agree with Christina. I think some of the evidence that have come out of other countries, maybe some growing evidence out of some other states, shows that maybe less virulent for some patients, but I think that the kind of jury's still out on exactly the impact of that. And I would expect that if you are unvaccinated, you're still going to be at a far higher likelihood to have severe symptoms compared to someone who is vaccinated. But I think your question's a good one. We're hoping that it will become less virulent over time with each variant. And to some degree, that benefits the virus, for lack of a better word. When you think of natural selection, part of the reason why it outcompetes other variants of the virus to be more contagious is because it may produce virus in larger numbers per droplet as it goes between people's mouths and noses. But also the virus, in order to propagate, if everybody got really sick and didn't go to church, didn't go to school, didn't go to work, the virus wouldn't spread very well. So to some degree, it's in the virus's best interest to make me just sick enough that I have symptoms and can make enough virus to spread it, but not so sick that I don't interact with others. So that's in many cases how these viruses kind of evolve over time. But I think it's way too early to tell yet in the US population how this is going to work. Some of the patient populations, for example, in Africa that were studied related to the Omicron variant were college students that were otherwise younger and healthier than maybe the average nursing home resident in Ohio or the average person who's at high risk in Ohio. So I think the jury's still out, but I think some early evidence is at least hopefully showing that it's not more virulent than previous versions, even though it might be more contagious or easier to catch. So hope that answers your question, Alexa.
Yeah, that's interesting. Thank you. Thank you all for answering these questions. It's helpful.
No problem. Well, thank you again to all the members of the press who are here today. We will plan on scheduling these in the future when we have news and information to share. In the meantime, you know how to reach our media relations team to get one of us on the phone to discuss things. We really thank you for being here today. And I really want to thank Drs. Koenig and Liscynesky who are here with me today. And hopefully everyone will have a good rest of the week. Take care. Thank you.